So we are recording. All right. So as you can see here, guys, right? Or ladies and gentlemen, I should say. I don't want to be sexist. Right?
Maybe you could put the chair higher. You could put the chair higher, I'm sure.
No, it may be as high as
you used to get hurt when you were
it actually may be high.
Oh.
It's actually quite high. Thank you. There you go. All right. So as you can see here, this is the plaque from the lab. You got the same one in your lab. And what you're looking at here is, so I'm going to slide this up to the side because I want to write on the board. So the first structure that's up at the top there is actually your brain. And if you remember, because this is at the end of neural, right? Because it's at the end of neural, you have to remember that you have forebrain, midbrain, hindbrain. The forebrain creates the cerebral cortex, which has and a medulla. So you have your cerebral hemispheres. Your hemispheres have a cortex and a medulla. Your cortex is gray matter. Your medulla is. It's interesting because they don't really refer to it as medulla, but what you really find in there are the globus pallidus, the putamen, right? See, even those people who don't know Spanish are laughing because they know what that word means. Right? Okay, so globus pallidus, putamen, right? And anybody else know what the next one is? Caudate nuclei. Now these are important because these are motor neurons. There are motor neurons in this. There are links. There are neurons that are linked. This is where movement disorders come from, like Parkinson's and Huntington's disease. So again, we're not in neural anymore. You should have learned this last semester. Now, separate of that, right? So your forebrain also has a second structure that's referred to as the diencephalon, which is a very important structure in the discussion for today. Midbrain stays midbrain. Hindbrain becomes the pons anteriorly and the pons posteriorly. I apologize. The pons anteriorly and the cerebellar hemispheres posteriorly. And then also sections off to be the medulla oblongata. Now, for those of you who like stoner movies, right? Adam Sandler, Waterboy, right? Mama says medulla oblongata made Gator ornery, right? And then Colonel Sanders made some little silly comment about his mother, and then what happened? He put him through the cabinet, he tackled him, right? So that medulla oblongata is it's a very important part. You guys should have learned about that because that's where you get decusation of motor and sensory fibers as they come down from the cerebral cortex to go down into the spinal cord, or it's sensory information coming up that's got to go up to this diencephalon, which we're talking about today. Everybody follow? And that's chapter 13, yes.
What does that say after cortex?
Cortex, oh, sorry. So it's gray matter cortex. So the cortex is made up predominantly of gray matter. And all this, so it's interesting because in the medulla, you'll have these nuclei, the globus pallidus, the putamen, and the caudate nuclei. But squashed in between those structures, you've got white matter tracks running straight up and down. All right? So the medulla is really white matter tracts with these nuclei populating between them as these fibers come up and down. Now, how do I know this? Clinical scenario. Here we go. 65-year-old male presents at the clinic. You're working at the clinic. The patient comes in. He's talking, he's responding to you normally. You can lift both eyes up, you can gargle and swallow, you can spit, you can chew. He walked in, but he walked in assisted. And when you ask him to walk on his own, he drifts. What's going on? What's that? Okay, so that's possible. Could be something with the ears. It could be an ear infection. Yeah, you check the ears are normal. What's next? It's tough, huh? Imagine now, you gotta think on your toes. What's next? Ears are normal, everything's okay with the ears. Check his vision. Vision seems to be normal. Nothing wrong with his vision yet. Yet, when I say yet, he's having a stroke. What side would it be on if it's his right side? That's weak. Left side. Everybody understand that? He's having a stroke. If it's the left side that's weak, then it's on the right side, yeah? So in his case, so you take a CT scan because you don't suspect of anything. You want to see if there's a bleed. You know that he suffers from high blood pressure. Take the scan, you don't see any blood. Is it a stroke? We don't know. Possibly. What's the cause? Transient ischemic attack. That's dissemus. It's when the blood vessel just decides to constrict down because it wants to, all on its own, due to lack of proper autoregulation. I got a blood vessel, it's supposed to be open, I decide to close it all of a sudden. What happens if I close a blood vessel off? No, well, be careful there, because if it tightens down too much, then they call it turbulent flow and you will get blood clot, absolutely. That is a big fear, yes. So not only can you develop a blood clot because of stasis of blood, but the most damaging effect is if it stays like that for a period of time that actually deprives the amount of volume of blood that reaches the brain. Understand? So we have these areas of the brain where there's dual circulation, there's dual blood supply, but then we have other areas where there's not dual blood supply. You understand? And those are the areas. So sure enough, it's a stroke. He loses weakness even more. Now it becomes disabilitating. His brain swells, goes into a coma. Take the scan. He's in the hospital. Take the scan. The CT scan shows a small semilunar infarct. Small semilunar infarct in the highway that runs between these guys. You understand that? In the white matter. In the white matter tracts. And there it lies the reason why, when it's all said and done and his brain, the swelling goes away, his arm flexes like this and his leg extends like this, and he's having to go to therapy to learn how to walk again. Everybody understand? From a small little area in the brain that's deprived, because it's a convergence and divergence of motor, sensory and motor coming through. Everybody get me? Now, this is important. Because the real discussion here isn't about any of this other stuff with the brain. So let's say now I erase all this. I'm going to talk about midbrain. I'm going to talk about cerebral hemispheres. None of that other stuff we're going to talk about. I want to focus on the forebrain and the part of the forebrain that becomes what we refer to as the diencephalon. Now, for those of you who have me for 2085, what's the first structure in the diencephalon? There are 3 in total. What's the first? What? The first one's the thalamus? So what's above the thalamus? Epithalamus. Yes? Yes, you know this. So you have your epithalamus. Then you have your thalamus. And then below the thalamus, what am I going to call it? Hypothalamus. So there begins the lecture. Because sure enough, on this model, you see right there, where I put the mark, the blue mark on there, that's the hypothalamus. And that, right there, that little blue mark right there, just above that little stalk, because the hypothalamus is connected. It's physically connected, and then it's physiologically connected. Did everyone hear me? Because the hypothalamus itself, I'll slide this over here now. Let's see, so the hypothalamus. All right, so let's talk about this for a moment. Epithalamus, what's his job? Well, the epithalamus, the main structure of the epithalamus, one of the main structures, not its only job, because there's a choroid plexus there that helps to produce cerebral spinal fluid. All right, that fluid is generated through the ventricles. That you should have learned last semester. Anybody looking at me like I'm crazy? Neural tube, all right? Yeah, 3 layers. You create a nodal cord, calls up, hey, nodal cord calls up to ectoderm. Ectoderm, what's up, man? Says, man, I noticed you just made that nodal cord pet, man. I'm sorry, I was just chilling and not paying attention. Creates a neural tube, comes down. Whew, now you got a neural tube. That neural tube becomes all the brain structures, but it's a hollow tube. The fluid that's in there is cerebral spinal fluid. And that cerebral spinal fluid is generated by choroid plexuses. It's recirculated back into the venous system. Yes? You guys go back and look at the dural venous sinuses. This is why traumatic brain injury is dangerous for the same reasons. Sorry. So the epithalamus itself has this structure that's referred to as the pineal gland. And what does the pineal gland do? Oh, we'll get it. It gets input from light. So with light input, who's responsible for light input? The sun. But how do we receive it? No, you're going too far forward. You got to go out to the beginning. How can you see me and I see you? Okay, good. The eye, yeah? So the retina, the outer layer of the retina, the ganglion cell layer is converging to create the optic nerve. The optic nerve is referring back. It's referring back to the brain. It's crisscrossing to create optic chiasms. They crisscross. Some of the fibers crisscross, and then they go back. A good portion of them will go back into the thalamus because the thalamus is your main sensory relay center. Now, those of you who have me for 2085, this is now you. Oh, yeah, that's right. I remember that. Right? Because I wrote it on the board just like that. It's the main sensory relay center. So all sensory information is going where? To the thalamus. I tickle the bottom of your foot. You little baby, and I tickle the bottom of your foot. Where's it going? Thalamus. Right? Me, the dumbass that I was, right? I always was interested in doing things right, that I shouldn't be doing. So one day, I found my grandma's bobby pin. And I opened it up just enough, and I said, wow, you know what? Smiley face looks like he needs something. Ching! And I got blown back, man. That was my first encounter with 120. Probably 240. Because it blew me back, man. It blew me back. My hair went, right? And I had like that Chia Pet afro, right? But it was like super duty, like it was already picked out. Right? Looking like Michael Jackson, right? Right? So here I am trying to hide it, right? Ain't no way you can hide that fro, right? That fro is out for good. So, of course, I just had to play it off, right? And I had this little U burn on my fingers. I'm hiding it so nobody sees what I did, you know? Luckily, the metal thing came back out. It shot back out, so along with me, right? So, as a matter of fact, I think it stuck to my finger, right? Because I burned my fingers. Now, that sensory information is going where? To the thalamus, right? Up to the thalamus. So much so that the reflex response would be muscle jerk completely away from the offending agent, right? Because of all that electrical input. So now, the hypothalamus is your master endocrine gland. Now, I know some books that will say that the pituitary is the master endocrine gland. Say nonsense. The pituitary is the slave to the master. It does the master's bidding. You understand? It does the master's bidding. The hypothalamus will tell the anterior pituitary when to release its hormones. You understand? So the hormones that the hypothalamus make are the releasing hormones. Those releasing hormones are peptide hormones, meaning that they're more than one just amino acid. Everybody understand? So we got to talk about this on the side here. On the side. So, all right, so let me slide this out the way for a moment. Because I need this out of the book. So hormones. There are hormones that are in the form of single amino acids. Single amino acids. Okay, they act as like neurotransmitter type like hormones. Understand that? Then you have peptide hormones, which means you got multiple amino acids. Okay? So peptide based. Then you have what? We were talking about on Tuesday, right? What's that one that young female comes in, right? She's 14, 15 years old. Obviously, you look at her, she's in phenomenal shape. She's got lots of muscle, right? But she's got low body fat. She's 14 years old and she's coming in, she's complaining of what? Not having her period normally. You test her body fat, she's at 7%. What should a female be at? Around 11. All right? Because you need extra cholesterol for the purpose of creating enough estrogen, because you're getting spikes of estrogen regularly the moment you hit your menstrual period. So the moment that you hit puberty. All right? So that's the whole reason why. Understand? Men don't go through that. We're simple, right? In the fact that from one cell we make 4, that's it. Ladies, your eggs are stagnant forever. They're stagnant the moment you're born. They're reduced down to less than, when you're conceived, you've got 5 million. When you're born, literally born, delivered, they go down to 500,000. When you hit puberty, it goes from 500,000 to 500 around. You release 1 a month for about 40 years. That's about 500, 480, 500 around there. And then when you don't have any more eggs, then you're in menopause. You understand? Well, those eggs never finish meiosis. They never finish meiosis. And we'll learn about that. So that's what makes females complicated. And that whole process of creating that egg and keeping it stagnant for all that long period of time is due to these, the rises and falls of these hormones, these cholesterol-based hormones. And that's the point. Okay? So you have cholesterol-based hormones, you have peptide-based hormones, and then you have single amino acid type hormones that are like neurotransmitters. They're neurotransmitters as well. Like, for example, epinephrine and norepinephrine. When norepinephrine and norepinephrine are in the bloodstream, they're going to act in that, because they're single amino acid. Dopamine as well. So remember dopamine. Remember I showed you phenylalanine to tyrosine, tyrosine to L-dopa, L-dopa to dopamine, right? Dopamine then to norepinephrine and epinephrine and norepinephrine, I believe, right? Norepinephrine, then epinephrine. That's a single amino acid that we're converting, but it can act in the bloodstream. It can act to do what? To raise the heart rate up, to cause the dilation of the trachea, and to increase flow, right? To deviate and increase flow to skeletal muscle. Does that make sense, guys? If I'm in a fight or flight response, yeah? Do I want to make sure that I have enough blood flowing to my muscle? Yeah, because I'm either running or I'm fighting. Now, those of you who know me, I'm tend not to be a runner. I'm the fighter. I'll start throwing elbows, right? I fight dirty. I use my fingers, man. My fingers, I have fingers of steel. Right? I can still do push-ups on fingertips. Right? Right? And I know where the special strike points are. Right? I can numb your arm up. Right? Make you hurt. You feel okay today, but tomorrow you're gonna be hurting. You know what they call that? The Chinese. I have a student here who has at least a Chinese last name. Huh? So it's a thing called DIMMAC, and it's this idea of strengthening the fingers, right, by constantly striking things that are hard, and then learning the points within the body that are weakest, and then of course then you use with the thumb, and then it swells up, right, and then you lose the ability to move your arm. You want to mess with me, that's what happens. Right? I'm not a violent man. Right? So I just like to be prepared. So anyway, hormones, guys, single amino acids, peptides, cholesterol. That fight or flight response, that's driven by epinephrine, norepinephrine, and dopamine in the bloodstream. Okay? And dopamine plays a specific role in the bloodstream in renal vasculature only. Through dopamine, through D2 receptors. Remember we talked about that. All of these, no matter what they're based on, they're still going to need receptors, yes? The difference between these guys and these guys is that the receptors for these guys are on the membrane of the cells. Everybody understand? And the receptors for these guys are inside the cell, either in the cytoplasm and or the nucleus. Did everybody hear me? And that's in your textbook. These work through proteins called G protein coupled receptors. GPCR. Look at the end of chapter 3. All right? GPCR. That GPCR is G protein coupled receptors. Everybody understand that? It's an acronym. G protein coupled receptors. There's only 3 of them. GS, GI, and GQ.
Couple receptors?
G protein coupled receptors. So, all right, so here's my analogy. Everybody ready? Let's see.
It's like a relay race.
Yes, it's like a relay race. Come stand right here. All right, so now watch. I got a signal. I want to say. Now you gonna stand here, but the door can't open. So I have to relay my signal through the membrane to her, and then she's got to send it to you. Right? So then she walks off, and then she tells the next person, 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 until finally that person, which is an enzyme that gets activated, goes down into enzymes that are inside the cell that will then trigger this whole process of turning DNA on. Okay? And that is, she's a second messenger. You understand? So that idea of no door. I'm not a key to a door that I can open and all of a sudden, hey, come on in, calcium, right? Or come in, sodium, or go out, potassium. You follow? Kind of thing. That's not what's happening. Right? So that second messenger is what these guys are. So when you hear second messenger, well, sure enough, the G protein coupled receptors are one of several second messenger systems that the cells utilize to relay information from the outside of the cell to the inside of the cell. Does that make sense? Yeah. Here we go. So there's the membrane of the cell. There's the big receptor. There's the hormone. When it binds, the G protein has 3 little cute particles. And you know the cute little particles, they grow up to be rotten. They turn out to be rotten, right? And they always got to leave home. You hope they leave sooner than later, right? So when this guy comes in, one of them stands off. Everybody see that? He goes running off. These 2 go running off. Everybody see that? And this one, he goes running off. Well, he's going to go, of course, he's going to go find somebody else to chill with it, right? You ready to follow? So now he's going over here and he's binding here. And the moment he does that, then all of a sudden now I make cyclic AMP. Everybody hear me? GS increases cyclic AMP. Well, cyclic AMP goes to, it specifically has, check it out. Here's the next messenger. Here's the next student, PKA. It's called protein kinase A. Means phosphokinase A, I apologize. Not protein kinase A. Phosphokinase A. It's a protein enzyme. And listen to the word. Phosphokinase A. What do you think this protein's doing, guys? It's taking phosphates and it's giving it to somebody else. And by giving it to somebody else, it's obviously got to be what? It's got to be taking it from somebody else. Everybody get me? So it's taking it from one person, giving it to another. Huh? So it's passing a phosphate. So that's what you guys are doing.
As you go along somewhere along, when I create a cyclic AMP and then this PKA gets phosphorylated, it gets activated, starts phosphorylating other stuff, and you start phosphorylating down. And that's how you turn the DNA on. That DNA, it activates this thing called the CRE, which is the cyclic AMP response element binding protein.
What?
It's a protein. It's a protein that's going to a specific area of the DNA. And it's driven by cyclic AMP. So they call it cyclic AMP response element binding protein. That gets activated. Sure enough, it goes directly to the DNA where the CRE, the cyclic AMP response element is. It goes to it. Ding! Sticks to it. Whoop! Stimulates whatever's next to it to be turned on in the formation of new protein. So this is the way we turn on cells. Do you understand? This is the way we turn on our cells. If I want to go through mitosis, maybe through this. If I want to go through meiosis, maybe this and something else. Do you understand? This is only one of 3 G protein coupled receptors, which is one of several different second messenger systems that exist within the cell. Everybody hear me? The others are, there's another one. It's called tyrosine kinase. And then there's another one that right now I can't think of. Oh, yeah, this one. It's called JAK-STAT.
What are you writing down?
These are all different types of second messengers. Right? So if you look here, second messenger systems, right? You have your G protein coupled receptors. You got GS, GI, GQ. Separately in the immune system, they don't just use these. They use these called tyrosine kinase receptors to turn the cell on. And then there's another one called JAK-STAT as well that they use. So these are other forms of second messenger systems. Why are we talking about second messenger systems? Because remember, we're talking about hormones, yes? We're talking about how hormones work at the membrane of the cell, right? But cholesterol is not included in this, yeah? You don't include cholesterol in this. Because these are all what? Second messenger systems, you got me? They got to be on the membrane. Everybody understand that? So they're only for amino acids and protein-based hormones.
You said cholesterol is receptors that are inside of the membrane?
Yeah, no. They're in the cytoplasm of the cell and or the nucleus of the cell. So they're literally floating. Here's what happens. The cholesterol, because of its lipophilicity and our ability to change. So because it's small, it's flat carbon chain, it's highly lipid soluble, but we can modify it to make it a little bit more water soluble. It can pass through the membrane, guys, the plasma membrane of the cell, and go right into the cytoplasm. And it goes into the cytoplasm of the cell and it finds its receptor there. Soluble protein in the cytoplasm of the cell. That protein will dock with it. It'll then separate because it's typically a dimer with two sets of subunits. The one set of subunits that prevent the active set of subunits from literally being active. When it binds, those subunits that are inhibitory, they separate. And that active part with the cholesterol hormone will move into the nucleus. Well, in some cases, the cholesterol-based hormones will go through the plasma membrane of the cell and go right through the nuclear membrane of the cell and go right into the nucleus. And there we'll find its receptor. How you like that? You understand? That's just the nature of it is. That's how it is. Because cholesterol-based hormones are something special. That's why, ladies, I know you want to lose that fat, right? But you got to have some fat on your body, right? Can't be too thin. All right? Can't be too thin. Can't be too muscular and have too little fat. Same thing with men. Men would have problems too. The problem is that the problems with men won't show up until you say like about 6 or maybe below 7%. Now I haven't had a couple students. I have a student actually who's in my class right now who told me he was at 6% body fat, and then I'm trying to understand why he's a little off, psychologically. Right? Man, sometimes, being in the gym too often and doing too much workout, You burn too much fat, that's not good. 6%, that's not healthy. It's not healthy. Give me about 7%. All right? And that really doesn't matter what size you are. I mean, imagine 187 pounds, 7% body fat. Yeah, that's lean, mean Terrell Owens. You know what I'm saying?
That's ridiculous.
It's scary.
That's scary.
I mean, you see these people and it's like muscles popping out everywhere. Right? They'll smile. Right? Yeah, all right. That's really lean, really super lean. All right. So we're talking about hypothalamus, master endocrine gland, releasing hormones. They're peptide-based hormones. They're going to the anterior pituitary gland, guys. So what type of receptors am I going to find on the cells of the anterior pituitary gland? Not this one. Not this one. I told you. This one's the one that we're talking about. Those were just two other examples of what a second messenger system is. But it's this guy, the G protein coupled receptors, that you're going to find on those cells of the anterior pituitary gland. Sure enough. Again, I'm full of stories. Anterior pituitary gland is associated with a posterior pituitary gland. The two are not the same. Did everybody hear me? The two are not the same. So look, let's go back. We'll go back to the model. So as you can see here, right there where I put the dot was where the hypothalamus is. Well, right here, so right at the end there's the bulb. That's the pituitary gland. So out in here in this inset, that's your pituitary gland right there. And if you look, this would be they didn't do too good of a job. Because what they should have done is, we're assuming because they're pulling it out this way, this would be anterior and that would be posterior. You understand that? And the two are not the same. I'm gonna say it one more time. Got it? The two are not the same. The anterior pituitary comes from a glandular structure that came originally from the roof of your mouth as gland. Just like we make gland everywhere else, you'll find out soon enough. The lung is a gland that develops off the GI. The pancreas is a gland developing off the primitive GI tube. The liver is a gland developed off the primitive GI tube. The GI tube is littered with glands from here to here. All right? All the way down, man. You got to keep the wheel greased, don't you? Everybody follow what I'm saying? Because otherwise, then you really are full of shit. Yeah? Damn, man, hard crowd, man. I should got like a huge roar out of that one, man. Jesus, come on. I know some of y'all don't like to talk about your poop, right? But you know it feels good, right? When you take a good shit, right? Just jokes. Remember I told you I gotta get you to laugh. Right? I gotta get you to laugh. We will talk about that, right? The S-shaped curve, semi-solid, right? That's the way it should be coming out. It's coming out like rabbit turds here. We got issues. You need to come see me. You know, the plop, plop, you know. Yeah, you can't have that. All right. So back to this. The anterior pituitary gland, guys, has an anterior part and a posterior part. And the anterior part comes from the roof of your mouth. The posterior part comes from the neural tube and the brain. I'm gonna write on the board. Relax. So the posterior pituitary gland is nothing more than an extension of neurons coming from the hypothalamus. Did everybody hear me?
No.
I'll say it again. I'll draw it on the board for you. So here, I'm gonna slide this out the way again. Here we go.